session. Actually, the talk which I'm going to give today focuses on one of the most, how would I say, it's a hot topic. It's something that brings so many arguments, fierce discussions actually, between the surgeon and the anesthesiologist in the operating room. To transfuse or not to transfuse. We all know the surgeon said, please give enough packed cells, and you say, well, the patient doesn't need it. And then the question comes, is it hemoglobin-based? Is it your answer? Or is it clinically based? Or is it the integration of these two parameters that make you decide whether or not you're going to transfuse the patient in the operating room, the ICU, or the department? And when you look carefully in the literature, it's mostly physician-based, i.e. we all have our ideas, not always evidence-based, on when we're going to transfuse the patient, or sometimes it's institutional or departmental-based. So I'll start with this, just showing one. There are many, but I'll go briefly over this. Physician-based. This is a very good study which was published, interesting, I'm not sure about good, but interesting study published last year, 2011. And these investigators looked at red blood cell transfusion practice in patients presenting with one of the most common scenarios for blood transfusion, which is acute upper GI bleeding. And they sent a survey, and then they went and looked at the people who answered the survey. They put such an effort into this paper. And they, first in the survey, they looked who selected the lower hemoglobin transfusion trigger. And the answer was that it was actually the surgeon. The surgeon selected the lowest hemoglobin threshold when we transfused this patient with upper GI bleeding. And also the young attendings, those who just did their written boards, and they were very much acquainted with the recent literature. However, and that's where comes the interesting point, when they went and observed these two groups, they found, well, that the surgeons were not that honest. I mean, on one hand, they said that we transfuse the patient when his hemoglobin was around 7 or 7.5. But actually, in practice, the hemoglobin threshold was much, much higher. Was actually higher than 9.5 or 10 in many of the cases. So there was a huge discrepancy between what they say they would do and what they actually did. Institution-based, again, blood transfusion is very often departmental-based or institution-based. I'm going to show you only a few studies, but this group from Canada looked at transfusion rate in 11 centers in Canada, including more than 40,000 patients, and they found transfusion rate between 24 to 52% in several scenarios like hip fracture, cardiac surgery, or in the ICU. But what was interesting is that the same centers selected either low hemoglobin threshold, like center D, you see, or center, I think F, that selected a higher hemoglobin threshold, F or C. So at least they were consistent. There are other studies looking at variation in the use of blood transfusion. This study from the JAMA, very famous study by Elliot Bennett Guerrero from Duke. He also showed such a huge variation, and it certainly was institution-based. I'm not going to talk in the next 20 minutes about massive transfusion like Professor Van der Linden has told us before. I'm not going to talk about massive transfusion because in this case we need to give blood. There is no threshold. We need to give blood. Just took this from the Mayo Online a few days ago, looking at this young woman, Jehovah Witness, who gave birth, who needed blood because she had massive bleeding, and she died after giving birth to twins. Her family refused to let her have a blood transfusion, and she died. So in these cases, there is no question the patient should receive blood. What I'm going to talk about is what is in the literature called the NE patient, the non-extreme patient, and it's defined as the patient without signs of shock and no massive bleeding. Okay, the patient in the OR who is bleeding, but it's not massive acute bleeding. The patient with the PACU, the patient in the department, that's most of the patient that we treat and we observe. Why not transfuse? That's another question, and it's another topic for another session, so I just go briefly. We're all acquainted with the problems associated with blood transfusion, whether it's errors or hemolytic reactions, viral transmission, infection risks, and three other concepts that were introduced in the last decade, which is TACO, transfusion-associated circulatory overload, the TRIM, very important negative effects on the immune system. It has been shown that blood transfusion, and I'll show it to you further on, increased infection rate. There aren't that much, many data to show that it caused cancer recurrence. It's hypothetical, it hasn't been proven yet, but there are studies to suggest. And of course, TRALI, transfusion-related acute lung injury, which is the leading cause, by the way, of death because of transfusion. I'm just going to show you one case which we had a few months ago in our hospital. It was a 26 years old woman who came to give birth. She was 32 weeks into her pregnancy. She had a thrombocytopenia, and on the follow-up in a high-risk pregnancy outpatient clinic, she was found to have elevated liver enzymes levels. And she underwent at a certain point liver biopsy. After the liver biopsy, she was bleeding to a hemoglobin of 8.8 gram%. She was stable, however, the obstetric group decided to transfuse her with PET cells and blood products after the liver biopsy. And she developed, within 3 hours, dyspnea, tachypnea, desaturation. That was her chest x-ray, showing the transfusion-related acute lung injury. She was admitted to the ICU. She developed acute lung injury. She was put on mechanical ventilation and had emergency C-section. On her C-section, and you're looking here at the on the data from the operating room, she was quite stable, as you can tell. She did not bleed much. Nevertheless, she still received 1 packed cells. Not enough that she got that packed cells and FFPs that called the TRALI. She got another packed cell, and she went out from the operating room with a hemoglobin much to my hemoglobin of 11.2. The baby and the mother are okay, but this is one example where one should not get blood or blood components and how it can actually cause morbidity. We also know that TRALI is, as I told you, a leading cause of transfusion-related mortality, so we should all keep it in mind. So why transfuse red blood cells? Well, we transfuse, that's a very easy question, to increase auto-delivery to improve tissue oxygenation. I have to remind the audience here, and mostly the surgeons that are not here, but many people transfuse because the patient is unstable, because the patient is hypovolemic, he's not giving any urine, he's oliguric. Patients, you hear physicians say that they gave the patient blood because he has a new AFib, or he's to make his cheeks red, or to strengthen the patient so he can actually go undergo physiotherapy after her or his hip fracture surgery, etc., etc. So these are not good reasons to transfuse red blood cells. Why to transfuse against to increase the delivery of oxygen to tissue? We have to remember that we have huge reserves, because we use only 25% of our oxygen that is delivered to the tissue. This is why we have a venous autosaturation of 75%. This is why we can actually perform most-to-most resuscitation. We get 21% of oxygen from the air, and we can still transmit 16% during resuscitation. So we have such a huge reserve on oxygen delivery. So how low can we go with the hemoglobin? Well, this is the most famous study, and it was performed by Weizkopf back in 1998 and published at the JAMA. What he did, he took volunteers, 16 volunteers, and he decreased their hemoglobin from 14 to 5. I'm not sure you would get the Helsinki for this currently, but at that time, he did it, and he did it by actually doing acute normal volemic hemodilution. He kept the volunteers isovolemic, which is very important. It's important to remember these patients were not hypovolemic. Okay, but their hemoglobin went down from 14 to 5. And what he observed is all those compensatory mechanisms. For example, the heart rate increased, the cardiac index as increased, systemic vascular resistance decreased, etc., etc. And as the mixed venous oxygen saturation did not change much till, as you can tell, hemoglobin of around 7 or 6, again with the hemoglobin going down all the way down to 5. And when you look at the wedge pressure and the CVP, you can see that the patient were normal bulimic, i.e. he kept normal intravascular volume. So you can go quite low without causing any problems with lactate or acidosis till the hemoglobin goes down to 5. So he showed all those, in that paper, all those compensatory mechanisms of increasing cardiac output, extraction ratio that increases, redistribution of blood to vital organs, etc. The Jehovah Witness gives us another opportunity to look into the question of how low we can go. And in this retrospective study, again from Weisskopf and his group, published years ago in Transfusion, they looked at 61 reports of massive bleeding. And in 23 deaths was attributed to anemia, all with hemoglobin of less than 5. In another study in cardiac surgery, also Jehovah Witness patients, 123 Jehovah Witness patients who got no transfusion compared to around 4,000 controls, that 65%, two-thirds of whom received that transfusion. And what they found is actually that myocardial infarction was, to say the least, less prevalent in the Jehovah Witness group compared to the control group. So even in patients undergoing cardiac surgery, not transfusion, keeping a lower hemoglobin rate does not cause increase in morbidity. Perioperative mortality in Jehovah Witness patients. This is another very important study. Again, 300 Jehovah Witness patients undergoing a variety of major operations, 20% emergency operations. And the post-op hemoglobin count was 8 or less. And they looked at the mortality of these patients. And what they found is that when the hemoglobin was between 7 or 8, none of the patients died. The real step was between hemoglobin 5 and 4, around a third of the patients died. So this is a retrospective data, again with all the faults of this data, but it gives us a hint that actually we can go quite low with appropriate compensatory mechanisms. Is perioperative anemia is a risk factor? Actually, preoperative. We see the patients in the outpatient clinic, preoperative, that the patient has anemia. Does it mean that he's going to have a higher morbidity and mortality? And there is no doubt. Anemia is a marker, yes. There are numerous studies. I just showed some studies, but there are numerous studies. This is one of the most important ones, published in Circulation 2007 by Mangano and Collier. And they looked in this perspective, multicenter, 70-center study on almost 5,000 patients. And what they found is an increase in death rate, in non-cardiac, and in cardiac complication when the hemoglobin, pre-op hemoglobin was less than 11 to 12. So anemia is a bad marker. In another study, okay, this one published by published also in cardiac surgery, patient undergoing cardiac surgery, 3,500 consecutive patients in 7 academic hospitals. And they also found that non-anemic patients had a lower rate of death, stroke, and acute kidney injury compared to the anemic patients. Yet in this study by Scott Beatty and his group, they looked at anemia as a predictor of mortality, perioperative mortality in non-cardiac surgery. And what they found is that the patient with pre-op anemia had a more than twofold greater odds of dying within 90 days of surgery. And again, this paper that included 300,000 patients aged above 65, showing that the incidence of cardiac events and crude mortality increasing when pre-op hemoglobin is going down, is decreasing. So we may conclude that preoperative anemia is associated with increased risk for morbidity or mortality. The question is not whether it is a risk. We know it is a risk. The question is whether we give blood, we can decrease the risk of morbidity and mortality. And I'm going to present to you the most important data. Actually, it's all randomized controlled trials dealing with this question, whether we see an anemic patient or a bleeding patient, non-extreme, as we call them, patients, and we see their hemoglobin 7.5, 8, 8.5, 9, should we give them blood or should we not give them blood? I'm going to overview the trick, the tracks, the TRALI, all these studies, a randomized study. So the first and most important study came from Hebert group. That was a multicenter randomized controlled clinical trials of transfusion requirement in critical care. That's what it stands for, transfusion requirement in critical care. It was the first large prospective randomized study performed in 1999 of red blood transfusion in critical care patients. And they included around 800 patients. The restrictive strategy was that patients were transfused to get their hemoglobin between 7 and 9, and the liberal strategy was to get the hemoglobin above 10. Excluded were patients following cardiac surgery and patients in shock. And what this study showed, overall 30-day mortality was similar between the liberal and the restrictive group. When they looked at subgroup, they found improved 30-day survival in the restrictive arm, those in whom the hemoglobin was kept between 7 and 9. When the patients were younger than 55, or the Apache score was less than 20, the mortality was much lower in the restrictive arm than in the liberal arm. When they looked at patients with cardiovascular disease, you know, we always hear the other physicians say, well, he has cardiac disease, we need to transfuse him, okay? So, with cardiovascular disease, the mortality was not much different between the restrictive arm and the liberal arm. It took actually more than 10 years for the next study to appear. This study was published in 2010. It's not the TRIC study, however, it's called the TRAC study, the transfusion requirement after cardiac surgery. Again, a very delicate group of patients. That looked at 502 patients. Again, a restrictive strategy and a liberal strategy. These patients received blood only when hemoglobin was less than 8, and the liberal, when the hemoglobin was less than 10 to get it above 10. And what they found that there was no significant, of course, those in the liberal received more blood, that there was no actual difference in mortality and major morbidity between the groups, i.e. those who received blood and those who did not receive blood. There are a few studies that came from a very interesting group of investigators, the Canadian Critical Care Trial Group. They did a few studies in a few pediatric patients with sepsis, post-surgical pediatric ICU patients, and those after cardiac surgery, pediatric after pediatric cardiac surgery group. And what they found is that there was no benefit from liberal strategy. Actually, that hemoglobin level of 7 is safe, and that reduced PQ loss, length of stay with restrictive strategy. So when looking at all these studies, you cannot tell that we need to use a liberal strategy in a non-extreme bleeding patient. This is a systematic review that was published in 2008 by Marek and his group in critical care medicine, showing that using liberal strategy actually causes harm. By now we know what's the harm, but just mention it. First of all, is the risk of infection is significantly higher, and also the risk of what back then was called, or it has now termed TRALI, transfusion-related acute lung injury. And this Cochrane, published 2 years ago, also shows that restrictive versus liberal transfusion strategy results in less transfusions, of course, less infections, and no difference in mortality and cardiac event. And they conclude that the existing evidence supports the use of restrictive transfusion triggers in patients who are free of severe cardiac disease, i.e. unstable angina or congestive heart failure. And this is the last, one before the last papers that I'm going to present on this subject. This is a retrospective analysis of 10,000 patients, a very good study from anesthesiology published last year. What these authors did, something very smart, they took all the anemic patients, those who came to the operation, hemoglobin of 6 to 10. Okay? They did not take the whole group, only those who came with hemoglobin of 6 to 10, and they looked at their outcome, whether they were transfused or not transfused. And what they found is that patients who received blood intraoperatively, okay, they had a more septic complication, pulmonary complication, thromboembolic complications, more wound complications, and increased mortality. So even those coming for any surgery, non-cardiac surgery, who received blood during the operation had a higher incidence of all those complications. And the same also in patients with burns. Again, 21 burns centers looking at what predicts mortality, and mortality was related, as shown here, to the number of units of blood transfused outside the operating room and total number of transfusions. Okay, and again, the number of infection per patient increased with each unit of blood transfused. The most recent study was published this year by this person who presented the data not so long ago, Carson. And Jeff Carson published this excellent trial. It's a focus trial, functional outcome in cardiovascular patients, surgical hip fracture repair. He took all the patients in those centers, 47 centers in US and Canada, 2,000 patients. Again, it's very hard to do this study. All those patients, mainly women, of course, 80%, as you know, of hip fracture surgery is in women. The average age is 80 also. So he took hip fracture patients with cardiovascular disease or with risk factors for cardiovascular disease who presented to the operation with hemoglobin of less than 10 grams per cell. And he randomized them to receive blood and not to receive blood. The liberal, almost all received blood because hemoglobin was less than 10. The restrictive arm, the threshold was 8 grams per cent, but he also used the clinical parameters, i.e. congestive heart failure, chest pain, hypotension, not responding to fluids. All these patients also received blood. The primary outcomes defined as inability to walk across a room without human assistance on a 60-day follow-up. A very interesting outcome, because that's what the surgeons always say. Oh, he cannot get out of bed. He is so weak with hemoglobin of 8.5. We need to transfuse him or her. Mostly with 2 units of blood. Now you don't use 1, you use 2. Okay, so what did he find? He found a median transfusion rate in the restrictive arm of 0, 2 in the liberal arm. The rate of primary outcome, i.e. walking, as you remember, was 35% in the restrictive arm, not different in the liberal arm, and rate of in-hospital acute coronary syndrome or death was not different between the groups. Also, it found no difference in mortality at 60 days and in complication rate. So there was no reasoning to give blood in this patient population. So we can go quite restrictive with transfusion in most patients, and that's the point that we get from all these controlled randomized trials. Again, in the non-extreme patient, it's not for the trauma patient. So before I end the talk, I just want to remind you, transfusion therapy practice, as we've seen, is variable. Blood isn't risky. We all know it is very risky. How low we can go? We can probably go as low as 5, but we don't want to push it that low. We usually go as low as 7 to 8. In some patients, we might want 8 to 9 threshold. Perioperative anemia is a bad marker. However, with transfusion improved outcome, it has not been shown yet. Maybe on the contrary, it may increase morbidity and mortality. With restrictive approach, no doubt, we've shown no negative effect on patient outcome. It may improve outcome, as I said, in some populations. We have this threshold in mind. This threshold actually came from this study in gynecology and obstetric surgical by 2 gynecologists who were smart enough to name their paper anesthesia in cases of very poor risk, some suggestion for decreasing the risk. Okay, so when they applied this 10-30 threshold, they knew it's not for all patients. That's what they said, in very poor risk. And I'm sure we can go down with these numbers, but still it's in very poor risk. So I think, and that's what I try to educate in my hospital, is that we should be in charge. We should not say, well, we do right in the operating room, we can care less, we couldn't care less what's happening in the other departments on the wards. We should be the winners of not my job award. We should not. We should take a lead on this subject and go out there for the surgeons and the internal medicine physician and teach them or educate them to go for a lower threshold. And in some places they've done so in Canada, in Australia, New Zealand. They've shown wonderful results in the recent meeting in the ASA, showing a huge decrease in the use of blood and blood product as a result of education. And I do think that the next guidelines for RBC therapy should be to keep the patient normovolemic, use blood transfusion, blood-saving techniques, and use a much lower transfusion threshold. Again,